Okay, our next presenter is Dr. RUPAK BISWAS. He will be presenting failed macular hole cases where the macular graft is the option. For his award-winning video, got the ASRS Best Video Award and Uretina Gold Award.
Dr. Nandi, thank you for inviting me for your course. But again, this is just to give you, I will show this, the technique of macular grafting, of autologous retinal grafting technique, which is very unique other compared to the other technique. At the same time, I will just like to give you an, comparison of what are the things available for a failed macular graft. So what you can do with the failed macular graft, what are the things available, and how you can compare with those two. So let us start with this. So this is a standard technique of, when you do macular hole surgery, preferably standard ILM peeling, but if you can do an inverse flap technique, that is, as Dr. Baral was telling, that is a better way out. But again, there is a lot of controversy which size to be, inverse flap to be done, and up to, it has been seen that up to 400 there is no difference between whether you do inverse flap or you do standard macular hole. There is controversy lies between 400 to 600, but more than 600, yes, the role of inverse flap technique is definitely much better than the conventional technique. So internal limiting membrane plug and gas endotamponade for recurrent and persistent macular hole. So this is Professor Rizzo has described this. But again, this is a standard what we do usually follow. They have here 9 cases they have shown, and all the cases were closed. So normally standard as of now we all use this. But again, this is, we are putting the only ILM part of it, which is actually ILM is a food process of your Muller cells. So it is actually a fibrous tissue, nothing else than the fibrous cells. So what it causes initiate a fibrosis in that area and drags the macula of the peripheral area into the central area, but by this way it comes closure and rest of the part fibrosis occurs. So the scotoma becomes less, but whether is it a functional, that cannot, only ILM cannot regenerate a retina. So that is a logic. So this is a technique where you can peel. So if it is your case, you know how much peeling you have done, but in somebody's case, then it is difficult. Again, you need to do a large area of staining and then try to find out. It becomes fragile, but again, try to plug it there. Now, treatment of large macular hole with internal limiting membrane, and they have put they have tucked into properly into the whole area, so that there is no residual of those membrane is lying over the area. So there are in this ILM plug, there is 2 techniques. One, all the ILM they put it into the hole. Another one, they put it into the hole and some part remains over the margin of the hole, so that the dragging and the fibrosis occurs. So this is in the tuck technique what I am has been described here. So this is another way out is, these are all about the ILM plug. Now when there is no proper treatment, there is multiple treatment. So what is here? So there is another group, they have tried of modified foveal enhancement. I think you all have come across. I mean, they have in a large macular hole with the soft tip cannula, they just advance the whole margins so that they come closure and then drain the residual fluid and then fluid air exchange, gas tamponade. It worked, but again, not in all the cases. There is another option is that lens capsule. So whatever is remaining in the eye, so whatever you take and put it there, the hole is getting closed. So lens capsule or posterior capsular flap can be filled up here. This is a technique, and this is a video which I'll just skip and I'll show it to you. This is by one of my friend, Dr. Manish Bapai. He has done. He had a case of retinal detachment with macular hole. Now the hole also closed and retina got settled. Now what happened after that? After 2 weeks, 3 weeks later, then superior, there was some area of retinal detachment restarted, and he advised for surgery. Patient came back after 7-10 days, the whole retina got detached and the macular hole again reopened. as usual what we usually see. Now he did not have, he had done a large peeling in the initial phase itself. He knows it very well that I have done adequate amount of the peeling and put it there, so the residual ILM is also not there. So what he did, he has to take out the posterior capsule with the scissor and forceps. Yeah, so with the scissor and forceps, he just cut the posterior capsule, the large area, and then tried putting it there. And yes, obviously, hole closed and the retina got settled. So this is another way. So everywhere you can see it here, this is a whole area is completely a fibrosis. There is no retinal tissue per se as such. Yes, the hole is closed, the retina is settled. We got it, but again, that is what we usually looking for is not the way out. Now, human amniotic membrane plug to promote the failed macular graft. Yes, that has also been tried with, by a lot of, Professor Rizzo has tried with this. They have shown that successful closure here, but again, you can see that there is a subfoveal fibrosis in this area as well. Now, another is there is a comparison has already been done by Dr. Naresh Babu from Arvind, and they have done a platelet-rich plasma with comparison of inverted ILM peeling for the large macular hole, which is comparable to the failed macular hole kind of situation. So their conclusion is that almost both platelet-rich plasma is equally effective compared to the inverted flap technique. So in either way is okay for it. Now comes to the autologous retinal sensory free patch transplantation for the persistent macular hole. So this is a technique which little different from the other autologous retinal transplant technique, because there the free flap is much more larger in size to put into it. Here I have devised a kind of a retinal trephine with which you measure the preoperative macular hole, and you see this area here. This is just simply you are trefining the superior above the arcade superior area of the retina. Yes, this is not architecturally, and the cone concentration is not as good as like normal retina, normal fovea, but yes, it is a retinal tissue. So it has some amount of the photoreceptor cells and the neurosensory retina as well. So you can see it here very properly. This trefining has been done in fluid. And then when this transplant, this is the graft, you can see it very clearly. The transplant is being, from here to graft is being placed over the macular hole area. And with the soft tipped cannula, just tucked gently. But at this time, you need to be very careful that your port should not be open. Otherwise, this can be sucked in. And then slowly, in a controlled way, you can, surrounding fluid, you can take out. Then donor area has been lasered and gas tamponade. Now, the difference between the other autologal ART and this, here we are using we measure the retinal, the macular hole size, the recurrent macular hole size, and then add up around 15% of that. So suppose if you have a 600 micron size of the failed macular hole, so you will take the trephine of 700 size. So 15% of the increase, this is in my initial stage. I used to use the same graft size. Then I realized that the graft shrinkage is occurring, and most of the time the graft is remaining within, and there is a surrounding area of remaining, a rim of macular hole is remaining. So then we have, when we have increased to 15% of this, then this is working properly and very well. Now this is a failed macular hole case where, after grafting, this is 6 weeks post-operatively, you can see the graft is very well placed, and the end-to-end attachment is also very nicely organized way you can see it off. So this is OCT. How functionally it is active? This is a comparison between, this is a normal foveal threshold of a multifocal ERG. So what we did it here. And this is the normal fovea. And next this is a standard ILM peeling technique by which the macular hole is closed. This is a primary closure, and this is with the failed macular hole with ILM plug, and this is your macular graft. It has a significant amount of the spike. So you can compare all in one chart. This is normal, this is repeeling with plugging, this is classic peeling, and this is grafting. Okay, so now this is there are again this is another, they have put the autologous blood inside, and then over that they have put the neurosensory retina. Again the debate comes whether the neurosensory retina over below there should be a blood or not, because blood again can degenerate the photoreceptors. So again, I'm not going into the debate of that, but this is another technique to hold the retina properly in the place. So now another evidence that yes, this graft is functioning, whether the vascularization of the graft and the attachment, this is the proof what I am going to give it to you. So this is another case of, this is postoperatively 3 months after that. This is a fluorescein angiography showing vascularization. This is 6-month OCT. This is 6-month OCTA is showing vascularization, but some amount. This vascularization is somehow taking a bizarre type of vascularization, not very properly, obviously. And this is 6 months of fluorescein angiography. And another case of, this is OCTA at baseline, and this is OCT at baseline. This is 6 weeks. This is 6 weeks post-op, and this is 3 months, graft vascularization. Similarly, another, this is a large size. This is more than 300, 3,500, 3,400 size of the macular hole, which also got vascularized with this autologous grafting. Thank you. So probably this is the way forward for recurrent macular hole or large macular holes.
Nice bouquet of cases, Dr. Biswas. So what is the success rate of, what is the complication you have encountered while doing autologous retinal graft? Because I have very poor experience. I have lost the graft. I have placed the graft under the retina. If the graft misplaced, I have to redo it again. So what is your experience? How many cases you have to do before becoming expert in autologous retinal graft?
Not really, Dr. Krishnendu. Actually, yes, that's what I was telling. The first case had a subretinal migration because it was a smaller size of graft, so I had a subretinal migration. Second case, I had a graft loss. Third case, it was there, but there was a rim surrounding it. So after 3 cases, first case I did it way back in 2015, end of 2015. So then after that 1 year, I actually lost interest of doing it. So that it is actually function, whether it will work or not. Then 1 year, after 1 year, again I went back of those retrospective analysis, and then again thought, and then I have increased the size, and this was absolutely successful. Now coming to the complication part of it, yes, this is a very simple technique, because there is a after around at 250 micron size, the 250 micron from the tip of that trifine, there is one more catch is there, so that even if you press it, it will not go and hit the choroid. But it is very difficult, believe me, to hit choroid, because the feel of retina and choroid is completely different. So it is very easy to differentiate, and there is only possibility is bleeding. The most common complication is graft loss, and second is some amount of the bleeding and oozing. But in a proper way, if we do it of initial trephination under saline and then graft placement in air.
So the catch is you have to have the trifine. You should get patented the trifine and market it. So that
it is available. It is available. It is available.
By experience.
Yes.
Like I have faced one case of graft loss in a like open macular hole case post surgery. So I put it under oil. So I redid the surgery again. I took the graft, and the second time the hole closed. Second complication what I faced, that I placed the graft, and after I put in on SF6, and after this thing 2 weeks, 3 weeks, the patient came with partial attachment of the graft here, and I don't have the video and OCT. I have the OCT, and the graft margin is elevated like this. The hole is, like you can see, the hole is there and graft is partially attached, and the other margin is lifted up. So I just did FGE and tried to reposition. While repositioning that flap area, I realized the other part of the graft was so firmly attached to the RP. I cannot move it at all. It was so much. It is very firmly. It is maybe like normal retina. It is attached to the underlying base of the RP, base of the macular hole. It is very firmly attached. I cannot move that, that graft from the other part of the RP. And finally did the FG and aspirated the fluid under the graft and putting on SF6 and finally the hole closed.
See, the experience what he is describing no exactly the same, because once the vascularization occurs, then it is an integrated tissue. So you cannot differentiate unless until you cut it. It is not possible.
Extremely difficult to remove the graft from the whole bunch.
Because this is a part of the, it is integrated into that retina. So it is not possible to differentiate between those two.
So it means it's definitively it's getting incorporated in the retinal tissue. So it's definitely useful if you have learned the trick.
Again, become 10 years.
Yes, it can become 10 years.
Any of these patients, later OCTA was done to see whether fovea is becoming vascular or not.
Those reports are there.
So we have this vascularization.
So even if you see the MFERG, the MFERG peak is much better than the conventional closure.
So doing OCTA.
Yeah, but this is one case just to show you. But may not be the all cases you can have that kind of a similar peak. But yes, this is probably the way forward that you can close the retina in a failed macular, close the hole in a failed macular graft. I mean, failed macular.
Which is the ideal site of taking this graft? Because the nature of the retina differs from the central and the periphery.
I completely agree with you, but again, I will not prefer within the arcade, because the arcade, the cone concentration will be more. But again, this is more risky because the scotoma patient will have the scotoma. And obviously, superior part is more preferable because you are putting the gas tamponade. Third is beyond the arcade, whether you are right-handed surgeon or left-handed surgeon, depend on in which eye you are operating. So you need to be comfortable enough to refine that part.
So which part do you prefer?
So if I do it
you being a right-handed surgeon.
Yeah, if I do a right eye, I'm a right-handed surgeon, so I will prefer in the supratemporal area. So it will be somewhere around, not exactly on the, foveal line. If you draw a vertical line, slightly towards the temporal side of that.
I want to add a few more things. Like fovea has the maximum cone concentration. It's almost 0 rod cells. And the other part of, you cannot compare fovea with any other part of the retina. So fovea has a 0 motor value that we cannot get from any part of the retina. So preferably where he's taking graft from the supratemporal area, I'm taking graft from the slightly supranasal area, not exactly the superior to the disc, slightly supranasal vessels. So from that area only, I'm taking the graft. So wherever you are possible, but don't try to avoid the inferior.